Cathy Violette, thank you so much for granting us this interview on the Spoken History Project. So I'm sure Dr. McGee may have kind of given you the rundown of the background of this and kind of why we invite people like yourselves to discuss their experiences is really to go beyond like a history textbook or something more standardized and get the stories of people who have been in healthcare serving patients, doing the work of moving their practices forward for long periods of time. And we hope to get an understanding of how healthcare has changed throughout the decades that you've been working and just the challenges you faced, the successes that you've had, and kind of your thoughts on where you see the future of healthcare going. And so I know that's a lot, but we will definitely break it down. So I guess to get started, I had an amazing time reading your CV. You've accomplished so many things. There's absolutely no way we can get through all of this in this interview time. But just as a background on Cathy Violette, you earned your nursing degree, diploma of nursing in 1977 in Massachusetts, and then ultimately throughout the years you just kept getting to higher and higher levels of credentialing, culminating in a doctorate of nurse practitioner, also earned in Massachusetts. Do I have that correct from your CV?
It's pretty close.
Okay.
Noreen,
Yes.
at age 17, I went to nursing school at Memorial Hospital in Worcester. Lived at the hospital in the traditional diploma nursing type program and training, where you actually learned at the School of Nursing and took some courses at Worcester State, then called Worcester State College. So I completed my diploma and my bachelor's in Worcester. I did a nurse practitioner program um, through distance education for Cincinnati, but completed all my clinical training still in Worcester and still at UMass Memorial. So I
Okay. So
did become a nurse practitioner with a master's degree and then went on to get a doctor in nursing practice, which is a little bit different, but more and more nurse practitioners are now being trained at that level, although you can still get a master's and practice as a nurse practitioner. So it's just a little different. It's okay.
no, thank you for the clarification and providing those details. I think that's great. And even within that, there's so many avenues of inquiry I have that I would appreciate if we could go down. But I think to kind of back up and get to the beginning. So I found it very interesting that you said at the age of 17, you knew you wanted to study nursing. And so could you please, if you don't mind, just kind of what tell the audience what was your inspiration for pursuing that? How did you know at such a young age that this is what you wanted to do?
Thank you for asking that question. Um, I lived in a very networked family. Our homes were all close together. It was very much the typical extended family that was involved in your life. My grandmother lived with me, and living with her and seeing her failing health over time was a driving factor for me. I learned how to help her feel comfortable. Um, so she passed while I was in just going into high school. So by the third year of high school, I knew that I wanted to help other patients as well. I did as a summer job. I worked in a nursing home in town, and I did candy striping at the city hospital. There were other activities that all really sort of let me know that that was what I wanted to do. Interestingly enough, I thought I would do pediatrics when I applied to nursing school as a junior in high school and never really explored that fully, but did explore research. And so it's I don't know what truly guide the person to choose, but my grandmother's influence was there. And in the 70s, many young women either chose to teach or go into nursing. There were 5 nursing schools in Worcester at the time. And so I was in the nurse club in high school. Much of that sort of prompted my application, and I was accepted a year ahead of my graduation. So I knew where I was going in my junior year.
Wow, that's really remarkable that you had this clear vision and then were, obviously well earned working up towards getting that early admission. And was this all in Worcester? So you're born and raised in the area as well?
I am raised right next door to Worcester.
Okay,
I am
great.
about 6 minutes from UMass University campus and maybe 11 minutes from Memorial campus.
Ah, okay. Yeah, yeah, definitely just right in your backyard, it sounds like.
Exactly.
Great, great. And so, all right. And so, yeah, now I would really love to hear more about what training was like for nursing at the time. And, I think even if at this point you wanted to kind of compare and contrast how it differs from modern day, since I know you're extremely active in nursing education as well. And so to kind of break it up, I guess, what was your kind of daily schedule like in your curriculum, and what kinds of skills were you being taught, and how much was your tuition, if you don't mind me asking?
So my tuition, and I received scholarship for it because my dad fractured his cervical spine and was immobilized for 6 months. So I got a scholarship, but the tuition was only $300. um, but then we also paid tuition for the college where I took gen ed. Basically, you take English, but I had tested out of that. Um, I had taken anatomy and physiology as a night course at my high school in my junior year. And so it was the identical course for anatomy and physiology for freshman year at Worcester State. So I would go back and forth to Worcester State certain times of each day on a consortium bus. Um, and we would be on the wards in full whites, um, including stockings and shoes and shoelaces that all had to meet the perfect requirement. And our hair was up, tied up, and a nurse's cap on our heads. Um, we went on the wards and took care of patients under the supervision of our nursing instructor. Then we'd finish up on the wards, have a post sort of conference to talk about a specific patient that was assigned, go through the study of their illness and the interventions that a nurse might do. And then we'd get class instruction in the Jaquith basement of the hospital, excuse me. And for about 2.5 hours, and then we'd go upstairs and sleep in a dormitory. It's still there. It's Jaquith building and is now OBGYN offices. So it's pretty funny that I went there over 50 years ago and I'm still there. That's where I work. That's where my
Wow.
offices are.
Yeah, that is something. Yeah. Wow.
But nursing
Um,
was very different. We were instructed to stand when physicians came into the nurses station to give up what we were doing and in a deeply respectful way to just allow them to accomplish their tasks. Um, Communication was usually through the charge nurse, um, but there were times that you would be instructed to report something directly to the physician when they were rounding. But physicians made rounds, And so you knew when to expect a provider to arrive.
I see. And so, you mentioned at the time when you were training, the kind of career options for women, broadly speaking, were teaching or nursing. And so, I guess the majority of the physicians were at the time, I'm assuming they were mostly male. Is that correct?
100%.
Okay. Yes. And so it sounds like, historically there was this very kind of like deferential relationship between nursing and physicians. And um, do you think, I guess one question I have is how was communication done between nursing and physicians at the time? Were you just going and speak, like, would they just come and speak to you? Would you communicate through like a written chart? I'm assuming, there was no
Oh,
electronic health record or anything at the time. So,
nope. They were
yeah.
notebooks, like binders,
Uh-huh.
and they had a convention of sorts, and nurses' notes had their own section. And you would write sort of a soap note, sort of, not quite. It was a little less descript in
Mhm.
its organization. And those notes would be dovetailed with a care plan that was in a Cardex. So each patient had its own Cardex spot that listed meds, active problems, and the interventions that happened every shift. So if they
Mhm.
were Q8 vitals or if they were blood sugars um, before supper or a specific diet prescription or a physical therapy prescription. People stayed longer in the hospital then. Um, you might see, for example, someone with diabetes, and if they've had a complication of their disease, they might be there pretty long term.
Mhm.
Um, and so you developed really deep relationships with many of the patients you cared for.
And would you notice that you would see the same patients kind of returning over time, or was it pretty much a different set of faces in the admission that you were
So
seeing?
that's an interesting question. As a student, I we would have a group of patients that our instructors knew very well. And so I might be on a certain rotation doing med surge, and someone else might be on the rotation in the operating room. And so she might have seen the surgery, I might be doing the post-op care. So
Mm,
there was always a little bit of that going on at the same time.
hmm
Um, and then as nursing sort of evolved a little more, there was team nursing. And so you might get 12 or 14 patients with another patient care assistant and taking care of them for the whole shift. But what it helped was the continuity and the knowledge of preference was it allowed for individualized care in a beautiful way.
mm,
Um, I knew a certain patient liked a certain kind of activity, and I could plan that. I could
mm,
plan, okay, she likes to walk down the side on the west side. I'll walk her at this time because it's not really busy down there then, and she won't
mm.
feel distracted or pressured. You know,
I see. Okay.
yeah, it was a really wonderful time to give nursing
Mm.
care.
Yeah, and we're speaking again about the 1970s going into the 80s. Is that
Correct,
correct? Yeah,
correct.
okay. All right. And then a couple of follow-up questions. So, how long was a nursing shift? You can speak to it from the perspective of a trainee or a practicing nurse. And um, I also want to get a sense of kind of who were the people that nurses were working with at the time? Like, were there teams of phlebotomists and nursing assistants
Yeah.
who would be around, or yeah, just kind of what kinds of tasks were you responsible for that there maybe weren't the kinds of support that we have now to do some of these like other tasks that nurses previously may have done.
So that's a really interesting question. I I took my examinations to verify I was um, competent to be a registered nurse over 3 days at the Armory in Boston, and so did all of my classmates. And so we applied for positions. I got a position as a graduate nurse and started the week after I graduated as a graduate nurse, worked 8 hours on a med surg floor and had one PCA working with me caring for 12 patients in the evening. So I worked 3 to 11.
Okay.
Um, there were different task sort of assignments for the nursing staff. And as a graduate nurse, I sometimes was assigned to be the med nurse for the floor or assigned a panel of patients. And it really was the charge nurse or the nurse, the head nurse, as she was called then,
Mhm.
um, her choices for the assignments. Um, but when we were doing the meds came up in a prescription bottle with the name, and there were little cards. You matched the card to the bottle. You put them in a little serving cup, and nothing was blister packed. Nothing was
Mm.
um, ready to go, so to speak.
Mhm. Mhm.
There was no unit dosing. We mixed all of our own IVs in the bags and put up the tubing and got everything ready and then administered to the patient as the med nurse. So
Wow.
there was no pharmacist available on the
Mm.
floor. Um, if you had a question about a particular med or you needed clarification, you could just dial the number and they'd pick right up downstairs. Um,
Mhm.
so the communication was easier in
Okay.
that way. Um, if you had trouble with the IV, there was an IV nurse who served the whole unit, and you would page her and she would come. I spent a year doing that activity um, in the 80s. Yeah,
Wow. Okay.
yeah.
And so, yeah, I guess for your to get your certification for nursing, and at that point, it was a registered nurse degree, correct? When you first
It was called a
graduated, yeah.
diploma. Yes,
Diploma. Okay. And
yeah.
how many years of training total was that?
3 years at living at
3 years.
the hospital.
Living at the hospital. I see. Okay. And at what point during your training process did you realize you wanted to do obstetrics?
Um, I I decided to take a position in ambulatory care after my second child. But I had been in a leadership type position on the evening shift before I went on medical leave for my son. Um, and so I had that background to let me know, okay, I didn't want to go back into leadership, although it was wonderful. It wasn't direct care, and so I wanted direct care.
Mm.
There was a position that opened up. I applied for it, and there wasn't any turning back. I have been there since 1983. I have been on obstetrics. I did not do inpatient OB. I only did ambulatory.
Mhm.
And as an NP, which is the last third of my career,
Mhm.
I have only done ambulatory.
And from again looking at your background, it seems that you're not only just doing the kind of clinical work, you're also engaged very much so in disparities in care and trying to improve outcomes for underserved populations. And so, if we could, I'd like to kind of hear about when did you realize that you weren't just going to go in and kind of, clock in, clock out, do that, the clinical work, but then also take on these initiatives that you've been so active in.
I think by virtue of my clinical work, I worked in a federally qualified clinic within the hospital system, but was still federally qualified. So in the time frame when I was delivering care, there were many initiatives in the city. Worcester Healthy Start Initiative was one of them. There were many that sort of framed my interest. And you can't help but fall in love with the population that lives around the hospital on the hill and comes for generations to your offices. I took care of mums and grandmoms and granddaughters. Um, so it was easy to pursue my interests along that venue. And I did have nurse managers, more than one of them, who really wanted to promote that. The hospital was very active developing the youth center in Worcester, really trying to help the population. There's an agency in Worcester that is a family service agency, and they really promoted all of the interests in a way that we needed to know our populations, and 30% didn't speak our language. So I remember saying to myself, I want a button that can say what I want to say from me to the patient in their native language. And we're there. We have some abilities to do that now. So
Yeah.
yeah, over time things can grow and develop into very beautiful skill sets.
Yeah. All right. So it sounds like I'm getting the sense that you very much believe in, these amazing systems and, technologies we have in healthcare. It's really only as good as, your ability to effectively translate that to the patient and make sure that it's serving their best interests in a way that is, harmonious with, their background and kind of, meeting patients where they are. And you really see that as like a responsibility of people within healthcare, it sounds like.
I agree with all of those statements. I spent a decent amount of time hospitalized as a young person. Um, and so I got to see who were the nice people and who weren't really,
Hmm.
um, who took the time to explain something in a way that helped a little person
Hmm.
understand.
Hmm.
And I saw my grandmother. And so when you're a consumer and you get to look and then you get to deliver from the other side, it's pretty interesting and has a profound impact on the choices you make personally.
I see. And in your work in the ambulatory clinic, what kinds of tasks and what kinds of cases or I guess patients were coming to you? And like I guess like what kinds of obstetrics related issues were you managing in your day-to-day practice?
So as a registered nurse, I worked in a setting where all the clinics were combined. So we might give allergy shots and we might do colposcopy with the physician and we might do high risk OB care. We might, I staffed a teen clinic for a little while. Um, while I was doing my bachelor's degree work, I did a lot of work with HIV positive women. So the women's health portion of my choices was pretty profound and sort of rooted in my family and my clinical exposures, you know. So yeah, it was a logical choice.
Yeah, I see. And, I'm actually really interested in this idea of care for HIV positive mothers. And what was the care like for these mothers back then?
Oh, so actually, Nobel Peace Prize winner Dr. John Sullivan was someone I got to sit in meetings with and his staff as they developed the strategies. There was a Dr. Sheila Noon who did lots of on-site research, trained us to give HIV counseling education, do the testing, and provide positive results for those who needed it. The 076 protocol was some of the first protocol that we worked within. And I will comment that the social framework that's a fabric of support around families has sort of frayed quite a bit
Mm,
in comparison to now.
mm,
And caring for HIV positive women is still a really important task, although we've reduced the incidence. And we know much more about how to manage the disease to be a long-term disease rather than a sentence of sort.
yeah.
But it's a lot. There's a lot of emotions within it.
Hmm. So I caught something you said. You said you feel the social support for families presently has frayed compared to the level it was at in like the 80s or so. Okay.
That's true. That's
Okay.
true.
Yeah.
Just in sheer volume of social determinants of health, it's really changed.
Hmm.
Um, we did see heroin addiction, we did see substance use disorder, but not at the level now.
Hmm. I mean, not to, ask you to comment on things that maybe are not strictly within your expertise, but do you have any thoughts of, why we are at where we at, or why we are where we're at with this kind of erosion of, social determinants, or yeah, why there's less support for these types of considerations, if you don't mind commenting.
So we're internationally mobile now.
Hmm.
We, I remember as a child growing up, I lived in a neighborhood where my mom and the other mom knew each other because they grew up in the same neighborhood.
Hmm.
That network isn't as frequent now.
I see. Yeah.
Many
Yeah.
families move with the choice for personal safety, for food security, for safe housing, all of those determinants. But even those families who are well educated are needing to make choices that move them away from the nuclear family a little. Um, and I think society in it of itself, I took home ec. I learned how to cook in school when I was in seventh grade. I see women now who are not really savvy at meal prep.
That's true. I may be one of those women, to be honest with you.
Honestly. And so, I marvel at women's strengths throughout history.
Mhm. And I would also like to hear a bit about, you have this great experience with, knowing how it is to work in the healthcare setting with, paper-based communication, just calling people on the phone to convey what you need to convey. Do you remember when the transition happened for you from that form of communication to the electronic health record?
I do because I sat
Mhm.
on many of the committees.
Oh yeah, please t tell us about that. I mean, especially
um,
I think from the committee
okay,
standpoint, that's fascinating.
I think in the late 80s, early 90s, they started to bring the internet to the workplace. The the communication through email and Outlook started. We were a pilot unit, so I got to see that. I was completing a degree in the colleges during the time and needed to do library research. So I bought my first computer in the 80s. Um, it just creeped in, and the more we learned, the better we got at it. There are some goods and bads. There's a lot of what you build and don't build into computer electronics and resources. We have an EMR that's pretty useful, and I've done telehealth. During COVID, I did telehealth with high risk patients. I now do a research project. It's all virtual. It's all electronic medical record. That's where I get my source of information. But it's still the humans that need to write the information down. So that awareness of what the important pieces of a differential diagnosis are, it's still there.
I see. And when do you get the sense that the number of documentation related tasks changed as the electronic health record became more mainstream? Do you feel you had less time with patients? Do you feel like it didn't affect it, or how did the administrative burden change with the introduction of the EMR from the nursing perspective?
There was a time where things became very siloed, and you really sort of, in order to incorporate that new technology in, you might have forgotten about some of the other pieces um, in a little bit of a way that affected your practice. An example might be, I would work side by side with the physical therapist who might come and take care of a patient while I was working the shift. And the physical therapist might make an observation, hey, can you work on this part, and directly um, influence what I did in my practice.
Mhm.
Now it sometimes gets buried in the EMR.
I see.
so, so there are risks, but if the human puts in the information, it is retrievable, and you can find it. Um, and there are strategies you can develop if you earnestly want to make it, smart phrases and all that. That's awesome.
Mhm.
You can really cut the time that you have to work in the machine and be able to
Mhm.
then work more with the patient.
Mm, I see.
Yeah.
And kind of along the lines of thinking of, these big transitions that you may have observed during your career, do you remember when kind of the culture of nursing changed from, as you were describing, you're in your all whites, everything has to be just so, to now where I'm not exactly sure how it is where you practice right now, but I think most people would, not blink twice if they saw, nurses in like purple, like leopard print scrubs or something like that, And so when did you notice that there was a bit more freedom with how you could present yourself and the kind of the casualness with how you could speak with other people in the hospital?
That has just been a really fluid change. Some of it um, has to do with media and social media. Some of it has to do with um, necessary changes. I mean, who said that only women can be nurses? Who said that you have to wear skirts instead of you're climbing up on a bed doing CPR? It'd be nice to have your backside covered.
That's a good point. I never thought about that. Wow. If there was
So
ever
some
a
of
case
the
to not
changes,
mandate skirts, yeah.
yeah, some of the changes were needed. Um, but some of the changes have, and it's my personal opinion, swung a little bit far on the pendulum swing. Um, I I wore scrub clothes because that was a requirement. But then I noticed that other disciplines were identically dressed. And if you observe interactions, they are still gender driven.
Interesting. Yeah.
Yeah. If
Yeah.
you just take the time to sit and watch, you might see someone who has a certain lab coat color be able to achieve different things than someone who's the counterpart and equally qualified, but has a certain other kind of outfit on. So,
I understand. I think I have personally observed exactly the kind of discrepancy that you're mentioning here. So, um,
or,
yeah.
we were particularly required to keep our nails short, our hair tied up, because the infection rate would benefit from that.
Yeah.
When people don't use the appropriate barrier equipment, that bothers me.
Yeah.
Um, I don't know that we all know each other as well now because the electronic world has impacted our face-to-face social communication,
Hmm.
and we don't interact as much.
See.
Yeah, so I think things have changed. I noticed some of my patients are more responsive if I text them than if I try to just call them. Is
Yeah.
that the burden of so many advertisements doing robo-dialing? I don't know. You know, things change, and you have to change with them, and you have to figure out how to keep yourself successful. Uh,
Mhm. Well, it sounds like, again, from your background, you have been able to accomplish that. And I think another aspect of your career that I found interesting was your involvement in training activities and teaching and kind of shaping the next generation of nurses. So, can you please speak to a bit about how you think training requirements have changed over time and the types of skills and knowledge that maybe were needed at one time but not another, or just how the repertoire of information and skills has evolved over what you have observed.
wow, that's a big one.
Yeah.
um,
I guess to start with, just what made you interested in nursing education and training, and we can kind of discuss more from there.
so
Yeah.
I will tell you that I have been interested in nursing education and training from almost the get-go. We were challenged to help our less senior nurses. There were little sister programs during my diploma school. There were um, requirements to present to younger classmates um, so that was always an activity. But I also, when I became an NP, earned an appointment in the medical school to train medical students and to train residents. So my primary appointment is um, an assistant professor in the medical school. And then I decided I wanted to teach in the graduate nursing school. So that was the secondary appointment. And I have noticed that they have accelerated nursing education, and sometimes the hands-on pieces of observation are not as gelled. I tell you that when I train I just did a lecture the other day about palpating the abdomen, and I've watched students in the clinical site not use their hands to touch the patient in the same way that I was trained. And we take time when we visit it, and they feel a sense of accomplishment when they get that aha moment. So that's important.
Mm,
But I've also noticed the communication between the physicians and the nursing staff has altered over time. Uh,
mm,
Sometimes my colleagues can be disrespectful, and it is an empowerment kind of behavior that makes me think, I wonder what drove that.
mm.
Yeah, and
Yeah.
and I don't know, but
Mhm.
we all hold a responsibility to interact with respect.
I think that's a good place of common ground that I
Yeah,
think everyone should be able to get behind. So,
yeah,
yeah,
yeah.
yeah,
There's a lot of work to be done, and it's done at lightning speed now.
I see. And so, I again, like your background, there was a long time between when you were a nurse practicing nursing to when you were pursuing your training as an NP. And kind of to your point, it seems like I don't know details of how you earn a nurse practitioner license today, but from what I hear, it's like you can essentially it's like a degree program. So do you still need clinical experience in order to pursue that route of training? And if you could kind of explain how that pathway is now, that would be helpful.
Sure.
Yeah.
So there's a body of knowledge and skill that's required to become a registered nurse. And when you choose to do an advanced practice, like a nurse practitioner, like a physician assistant, like a nurse midwife, there are different sort of streets that you might go down within the neighborhood of advanced practice. And you might, for example, I had to do international kind of world health as one of my courses. I had to take um, a certain number of specific clinical hours in. I was able to organize my own clinical experience with some of the best of New England, but my classmates were in rural America, in maternity deserts, and the way that you function really depends on the place that you're functioning within. Um, so I had the required, I think it was 60 credits of advanced practice study in the biology of delivering care. And I we used the national organizations that physicians use, um, and dovetail with the national organizations that nurses use. And it's sort of stepping on the middle of the fence, knowing much of this, that means the basic knowledge to care for the lower risk or the high risk, depending on your education. Um, I collaborated with my physician leaders over a number of years before I even decided to go into an NP program because of the setting I worked in. And when I said I want to be an NP for high risk OB, the chair of the department said, I'd support that. So, and then I met with nursing and they said, I'd support that. So I got to do those things because I wanted to and I wasn't afraid to try. And you
Mhm.
have to be not afraid to fail. Sometimes you might not get it right perfectly the first time, but I was fortunate. I was trained, and did very well. Took a certification exam, and was immediately practicing as an NP in my first job, but under the supervision of a physician. And so I would go to her when I had questions. And then in the last part of this decade, we will see independent practice of advanced practice clinicians, NPs included. I would never, and that's my personal, I would never develop my own practice outside the hospital. I like what I do and where I do it.
I
um,
see.
yeah, but
Yeah.
there are standalone practices who have a collaborative agreement with physician-based hospital practices.
Mhm.
Yeah, I mean, there's so much to the necessary knowledge to do that.
Mhm.
Um, yeah, the contracts and all of that doesn't appeal to me.
Yeah, I mean, that brings up an interesting point about, just how, I guess, how much consolidation there has been in healthcare as well. Just, to your point about contracts and agreements and like which system like is owning which practices. And it seems like there's an increasingly smaller and smaller number of big systems that are kind of gobbling up these smaller practices. So, have you observed any of that where you practice, and do you think it has affected nursing practice in any way you can think of?
So I'm going to challenge you. You used the
Uh-huh.
word gobbling up.
Yeah.
I might think that it's provided a lifeline. Um, we're in central Massachusetts, and yes, we have a big system. Um, but how would patients who are in a big system in upstate New York be able to get the same level of care and access that we have here?
Hmm.
You can travel an hour and be out of the state, right? In
Yeah.
any direction. Think about the rural areas. It's by necessity that
Mm.
the bigger hands are reaching out to help the little hands.
Hmm.
Um, so I think it's important. I think it's done with caution, and I think it needs to be evidence-based. And I
Hmm.
don't think we're there right now.
I see. All right. And then, just in the interest of time, I know we've taken almost an hour of your day, and we're so very
Thank you.
grateful for you being so generous with your stories and with everything you've shared. I think it's incredibly valuable to kind of hear these, this perspective to get like a humanistic perspective on, how these changes have occurred over time. So I'd like to just give you the opportunity if there's anything we haven't touched upon that you think you would like to convey or about your career or changes you've observed. You're welcome to do that. Or if you feel like we've covered everything, I'll just ask some final closing questions.
Why don't you ask me what you're interested in, and I
Yeah.
I will answer.
Sure. Okay. So I'd like to know that out of all the changes you've observed, what do you think, which change do you think has been the most beneficial to nursing care? And it can be something related to the infrastructure of workflow. It can be medical technology or medication that you think has really made a big difference. Um, just, anything that you think was, wow, it's like, I'm so grateful that we had this change come about while I was practicing.
That's a big question. Um, so I was listening this morning, and one of the biggest things that has happened for women's health is is the development of cancer detection, right? Lung cancer was one of them, cervical
Hmm.
cancer yet another. And so discovery of a pap smear and then discovery of HPV and its vaccinations has saved so many lives.
Hmm.
The tobacco cessation projects, um, the vaccines, have saved. I have done a lot of work in the realm of fetal anomalies and the fetal anomaly care. Um, and vaccines are associated with anomalies. If you don't have a vaccine and you get a viral illness in a really important time, your your fetus can have an anomaly. Diabetes care has really gone in a beautiful direction to help prevent the complications of diabetes and morbidity and mortality around that. So those are, women's health has been the thing throughout for me. Um, Contraception and its ability to make one's own life choices outside of um, intimacy value, to be able to just choose. That's important. Um, I don't know what it'll change. I don't know what will happen. And we have to ever evolve and provide for the right human experience.
Well, very well said. Yeah, and I think no one would argue that, everything you mentioned hasn't been an extreme success for not only, women's health, but I think, the society at large, because, you can't have a healthy society without healthy women. So, um, yeah, and then I guess, are there any aspects of women's health that you think really need more attention, and that, as a not only a medical community, but as a society, we should be focusing more energy and resources on? I know everything can always be better, but is there
Yeah,
something you
there's
see
a
in your
whole lot
practice?
that can.
Yeah, yeah.
um, so I'm participating in some patient-centered research that has to do with support of the woman during her pregnancy and early postpartum to try to achieve the wellness levels that they can best achieve, right?
Mhm.
And we're studying how the women's needs are. I think that needs to continue. That's
Mhm.
really important because the American woman needs to do quite a bit in a short time. And the mental health stuff that's happening
Mhm.
shouldn't be happening. It
Mhm.
should not be that way. Women should get to care for themselves and their children in a better way.
Well, yeah, I certainly hope we'll get to one day learn from this study you're doing, and hopefully move the needle on that. I think it's important work.
It
So
would be
thank you
great.
for that. Yeah,
Thank
yeah.
you so
And
much for asking the questions you ask.
oh, well, thank you. Yeah, I mean, your answers were fantastic. I think everyone listening to this interview will learn a lot, and it'll give them a lot of food for thought. And I guess, just as the closing question, I'd like to know, if you had to go back and, choose a career all over again, would you have chosen a different one, or are you completely happy with how things have worked out for you?
I would not change what I did.
All right. I think nothing more needs to be said. I think that's a great place to end.